good. So this is Diane. She's consented to have this lesion taken off her scalp. So this is a mobile lesion. It's just underneath the surface. So if we're going to freeze it, I find if we put some xylocaine underneath the bed of the cyst, it breaks down some adhesions and pops it up from the scalp. Makes it easier to come out. That doesn't hurt too much, Diane?
Doesn't hurt at all.
That looks good. You can see it popping up a little bit. How long's it been there?
Probably 4 years, I think. Gotten bigger over the last few months.
So I find that deep injection is probably sufficient. I usually do one superficially as well, just to make sure that we're well anesthetized. And it kind of gives me a track to follow when I'm opening it up a little bit. But you could argue that this is redundant. So medically, Braden, do you remember what we call these?
It's either like a trilemmal type of cyst.
Yeah, so they used to be called sebaceous cysts.
Mm-hmm.
They said kind of got away from that because it's kind of a misnomer. The type of cyst was based on the cell type from which the cyst formed.
Mm-hmm.
So a cyst is just a fluid-filled cavity by its definition. So sebaceous cyst would imply this comes from sebaceous glands, which isn't quite accurate in this case. So they're actually been broken down mainly, your point is correct actually, but they break them down mainly into pilar cysts or epidermoid cysts. Both, again, depending on what tissue type you're originating from. Epidermoid refers to the epidermis, or the most superficial layer of the skin, and pilar refers to the cells at the base of the hair follicle, which is likely more relevant in this case. Feels okay?
Oh yeah.
So I typically will always just check to make sure that you can't feel anything. No pain there at all?
No.
So then I'll use the scalpel just to open this up superficially, and the key with these is just to proceed slowly. The reality is you'll always be successful getting these out. It's just going to be a function of whether it comes out completely clean with the capsule intact or whether it has to come out in pieces. So often that time it just requires us to be a little bit more patient than anything else. I tend to like using these curved butterflies or Kellys in a form of sort of blunt dissection. Again, you can use a sharp dissection, but I find it sort of comes along easily. So right now I'm not deep enough, so it won't open up. So what I'm going to be looking for, the capsule of the cyst is sort of a pearlescent appearing lesion. And the one thing I do warn residents and people who are trying this for the first time, the scalp can bleed a lot. Just don't be dissuaded by that, it's not a problem. So you can see here this area is opened up. So what I like to do once I have a little bit of an opening, is I'll put the Kellys underneath and just use the scalpel to extend that a little bit. So, and again, so if we see it hit a little vessel, you'll see it starts to bleed a lot. But what we're looking for, you can see it there. I don't know if you can see that, Braden. It's got a shiny material, and that's the capsule. So I'm just going to extend this backwards a bit so it'll be easier when it comes out. And it will seem to be almost wanting to push itself out to a certain extent, and that's partly because of the anesthetic we put around beneath it. If we did it properly, we put back pressure on the cyst. Now this one's a fair size, so we may have to extend the incision a bit, which isn't a big deal. So this is again a reason why I like the curved dissection better. It allows us to break down some superficial adhesions with hopefully not breaking down the capsule. And this is again where I just caution you, a little bit of patience goes a long way with this. So just in terms of feeling, I can tell there's a little bit of extra given the back, so I'm going to extend that a bit. Or I should say it's a little bit more adherent towards the back. Just going to light source here. You're still feeling okay, Diane?
Oh, yeah. I don't feel a thing.
So when I reverse this, you'll see it start to pop out. Just like that. So I'm just breaking down some adhesions behind it. Is it. Right there. No problem with that. I'll show Diane that after we're done. And the nice thing with that is when you get the whole capsule, then you know that the recurrence is less than 2% when the whole capsule comes out. Regrettably, for reasons we're not quite clear on, people who tend to form pilar cysts tend to form recurrent pilar cysts, and this is the second one we take off of Diane inside of 2 weeks. So now we'll just suture this closed, and then we're all done. That's good. You can stop.